We'll check the audio. Hi, everyone. My name is Gupta, coming to you from Orlando, Florida. I'm at the American Society of Regional Anesthesia fall meeting. This is our chronic pain focused meeting in Orlando, Florida. And this has been already a huge success of a meeting. We have a tremendous audience, almost 1,100 attendees, registrants for this meeting. And we have a great exhibit hall, a fantastic program of lectures and workshops. And I think one of the record-breaking over 400 abstracts submitted to this meeting. So far, it's already been a hit. We've had excellent interactions, engagements between the participants here. And hopefully, I'm going to meet some of the people from the meeting here, and they're going to come by and stop by in the corner and chat with me. But if you're listening and watching and you have some questions, I'll try to keep an eye out on the comments and see if we can discuss any of your comments or feedbacks or questions about the meeting. I do want to mention that there will be material that comes out of this meeting that you'll find available on the ASRA.com website. Also, I want to mention, while we have time, that the ASRA spring meeting, which will be in Hollywood, Florida, near Miami and Fort Lauderdale, is next spring. So if you're interested in acute pain and regional topics, point-of-care ultrasound, that's where that meeting is really going to shine. And based on the meeting that we had last year, I think the attendance is going to be gangbusters. So it's going to be one of those meetings you definitely don't want to miss out on. That's going to be in the spring. Go to ASRA.com. You'll find out all the details about the dates and the location, the hotel for that meeting. Registration will open up in a couple of months. What you should know leading up to that meeting is if you want to submit an abstract. The abstract submission process is right around the corner. Shortly after this meeting, we're going to open up the abstract submissions for that spring meeting. So if you're interested in submitting an abstract, like we had over 400 accepted to this meeting, I expect it's going to be something like that for the spring meeting. I encourage you to kind of get on your toes, start working on your projects, and pay attention to the details of when the website opens up for those meetings. Next fall, we're going to have the ASRA fall meeting. That's going to be in New Orleans. And we have a really interesting program set for that. I got the chance to peek at the program for next year's fall meeting. Alexios Karyanopoulos is going to be chairing that meeting. He's a PM&R and neurology trained pain physician. And I think he's going to bring a new perspective on how the society as a whole looks at pain management and from a full multidisciplinary point of view. So I encourage you to pay attention to all the notifications about that meeting and where those subject matters are going to draw people in from other organizations, other specialties. So from this meeting, a couple things that I've noticed so far. There has definitely been a focus. Dr. Amy Pearson, who's the chair of the meeting, has definitely been focusing on making connections. A lot of the topics and subject matter for the talks, the workshops, the Ask the Expert sessions are about making connections. So this is connections in medicine, it's connections in between specialties, connections between patients, but also connections between the providers and their own wellness for their practice. One of the topics for the refresher course series this morning was on headache. Headache's a huge topic, and a lot's been going on in headache. And when we have some people that kind of talked about that today, we'll dive into that a little bit more. Peripheral nerve stimulation was also a topic today that was emphasized. Peripheral nerve stimulation is evolving rapidly as the devices get smaller and lighter weight. The uses and indications have expanded. They've gone into not from just chronic pain, but transitional pain and even some acute pain settings. So a lot of buzz and excitement about the role of peripheral nerve stimulation and how that's going to affect prevention of development of chronic pain, management of chronic pain, reduction of opioids, and hopefully even provide some therapeutics that we didn't have options for in patients that have very difficult to treat pain. Some of the other topics mentioned today was about the overall well-being of a practice. Practices, particularly in our chronic pain colleagues, they're often very directly attached to the details of the practice, billing, employees, staff, how the patient flow goes, following up with patients, the logistics and the management of the entire group. It's a complicated task on top of the medicine that you're trying to deliver. And so some of the topics today we're discussing how to improve and get a better handle on that, how to deal with the stress of dealing with an office and billing. And one thing I want to emphasize is the advocacy that the society does on behalf of our physician and provider colleagues in this regard. One of the key components of billing is CPT codes. Oh, hey, I've got some of my friends here. Come on in. So we're going to stand right about here so we can, the camera's way over there.
Okay, gotcha.
Hari, how are you? It's good to see you. We got Hari Kalagara and Jarna Shah. They're joining us now. I'm going to give you guys this mic. There's a little microphone here. Just kind of hold it as a microphone as you're passing between each other.
Do you need to hold it? Do you need to
Just hold it. Just use it like a hand mic. Yeah.
Okay, gotcha.
And so we're going to be talking in there. Let me see. Hari, come on in this way a little bit.
And are we starting at 15?
Yeah. Okay. Hang on one second. We're already started. We're already live. Yeah.
Well,
hang on one second. Let me check some audio. Just say hi real quick.
Hi.
Yeah.
Welcome to the Asana Fall 2022.
Oh,
it's a shame we're missing everyone who's not able to make it, but hopefully you'll be able to come on to one of these in the future. It's a good group of people. We've got a lot of different stuff that's been going on. Amazing program this year with Amy Pearson putting it together.
This is my first time.
This is your first time?
First time.
So you normally come to the spring program?
No, yeah.
Yeah. So what is it like?
Gotta wait a second because it's a delay.
Just came in, so
Literally, you just drove in.
Just drove in.
Just drove in just for this prompt
Yes.
time.
I'm hoping I won't be lost with the chronic pain people.
No, they're a good group.
No?
They're a good group.
The delay is killing me.
Fine. We got good regional representation.
Nice.
Can you see it on that screen there?
Have you ever been to the regional meeting?
There.
Yes,
Is that better?
I go religiously. I love going to the spring one. The regional community is fantastic.
We still have the eye
regional
tracking
community is
going on.
really close and tight.
Yeah, we got.
Oh,
Come here. You're on live right now.
Yeah.
We got eye tracking
I
going
love the
on.
spring conference.
So-
The first one I ever went to
No. I want it, but I don't want that
was
box to
the
show.
World
Problem is I
Conference
can't
in
see
New
on the
York.
monitor screen back there while I'm doing the changes.
Yes.
I'm gonna turn
I guess
this
I'm just
around
going to hold
so you
down the
can-
fort here while everybody abandons me. It's all right. It's okay. I'm used to this. I'm used to this.
Okay.
So I'm trying to find ways to
With the box on it.
No, it's good.
It's cleaning the output, is it? I can see it here. Is it on there? Cleaning the out, yeah?
It's on. It's super bright though. The color is all.
Yeah, did you adjust the... Yeah, you've adjusted, yeah. That's you. You can see it on here, but it's not on the output. Good.
Okay, good.
That's you.
Okay, we're back. We got some technical difficulties worked out.
Stuart first.
What's that?
Oh, you should chat with Stuart.
No, we did.
Get over here.
We actually had a whole session yesterday trying to get everything set up, and then sure enough, when I started, he wasn't here, so I had to figure it out on my own. So I'm a little behind. Okay, so just as a proper introduction, I'm gonna give you guys the mic back. Yeah. So this is
All right. Hi
this
there.
is Jarna Shah and Hari Kalagara. Come over here a little bit so we can get you guys in the.
Hey, I'm Jarna
Yeah.
Shah. I'm down at the University of Arkansas, originally from Chicago, and recent Southern transplant for the last 2.5 years.
Yeah.
I'm Hari Kalagara. I'm from Mayo Clinic, Jacksonville. So I basically do more of regional anesthesia, and nowadays I'm just doing POCUS.
Yes. Seems to be the POCUS king now. You're just like taking over the world literally in point of care ultrasound.
That is the future now.
Yeah, it is. This
is my first
future.
fall fitting.
Yeah.
So I'm very excited and to see.
So I've got a mic, so you guys can just pass that between yourselves. So before, when I was doing the introduction, I was talking about the fall meeting and some of the innovations and the topic areas sort of emphasized during this meeting. One thing I noted was peripheral nerve stimulation. I know that's something that you and I were talking about earlier today. Where do you think peripheral nerve stimulation is right now? What do you think that you're hearing at the meeting that's interesting you about the topic?
We have a decent amount of peripheral nerve stim courses. I taught one this morning on ultrasound-guided lower extremity PNS blocks. There's a lot of advancement in the field of PNS. The literature is still lacking, but I hear that it's in the works, which is going to be helpful. The biggest issue most providers are going to run into, whether you're at an HOD or an ASC, is reimbursement. Mm-hmm. And I think that becomes a challenge for a lot of the stuff we do when it comes to PNS. But I think there's a lot of promising technology with how we can target nerves in a more direct way. And especially translating those regional skills into the chronic pain world, there's a lot of room for using those skills and translating it for those patients.
What are the most common PNS you are doing there?
It depends on what company I'm using. We've been involved with a lot of different studies. So I'll see a lot of total knee pain, so after a knee replacement, so chronic knee pain after a knee replacement, or even axial lower back pain. If you have some sort of peripheral nerve entrapment, I'll do it for that, including indications like pudendal neuralgia, as well as people after ankle surgeries, suprascapular nerve. You can target brachial plexopathy. Some people will even use it for like occipital neuralgia or stuff like that as well for occipital PNS.
And this is happening how far after the injury or the origination of the pain?
Great question. So it depends if you are looking usually 2 to 3 months out is where this kind of period starts. When you have the subacute period and then you go to the chronic period. So a lot of the PNS I see in the clinic and the referral base I have is more than 2 to 3 months out from surgery. Mm-hmm. There has been a push to look at that peri-surgical period and see what we can do to optimize that in terms of outcomes. But that's its own literature. And I will digress and let me defer to you because this is your area of expertise.
It's a good thing. So we recently, if you see the publications, we use the neurostimulation in a different way in the acute pain settings. So Bansi was pioneering in doing those studies. So what we do is we use the local anesthetic and we attach the stimulating catheter to it. So now every day we go and stim the catheters. Okay, in spite of the local, you will be so surprised with the dilute local anesthetic. You can turn your currents and stim the nerves. Okay, so it's called a dual stimulation. So future will be like that. I don't know whether you have seen Dr. Sanjay Sinha.
I was just talking.
Yes.
So it's like, tell me more.
He is working for FDA approval for a specific catheters. They go in like a peripheral nerve catheter, and it has a stim inside stim with a same like a PNS. So it automatically like a TENS machine. So it stims.
It's a built-in battery and generator and all that stuff. There's no external box.
No external
box
or
piece.
anything.
Yeah.
So your local anesthetic.
This product is not available yet. It's future, not FDA approved. Still going through patents.
Yes.
So this is still prototype work.
Yeah.
But that's the best
but it's
part
interesting about the.
It's like learning what's on the horizon.
Yeah. This is still
so we are
innovation.
doing a sort of a mini PNS in a different way from you. In an acute pain setting, especially one of the guy, our colleague, Dr. Rakesh Andakappam from Iowa, is doing phenomenal work in this aspect. And we even applied for an ASRA grant.
Good.
So for a major research in this area.
That's great. Yeah.
Let's see.
For those of you who don't know, ASRA actually has research grants.
Yes.
Not a small amount. Sometimes quite multiple tens of thousands. Yeah, I don't know if I can get to the chat right now, but we can later. But if you go to ASRA.com and look up grants, we have chronic pain and acute pain side focused grants and educational grants and new innovator grants. So there's different levels and tiers for people trying to do research. And when people are talking about what's the value of a membership in the organization, a lot of those dues, there's different things that they go to. And one of them is to fund some of these grants to make sure that we can continue to generate good, high quality research supported by our organization. So, and I believe you were a recipient of one of those grants at one point, weren't you? Didn't you have
one of my colleague, Harsha Santanam?
Harsha had one?
Harsha had
okay.
One. Harsha had one, and this year we are hoping.
Yeah. You're like, I still have a chance.
Exactly. Especially because it's a sort of a PNS what we are doing.
Yeah.
So it's very useful, especially for the amputations and stuff. So you can leave it for 5, 6 days, 7 days. Usually that's the best way to do. Yeah. So
when we look at peripheral nerve stimulation, so there's obviously it's in the exploration phase. People are testing it out in different places, not only the techniques, the parts of the body, but also the logistics. Do you bring somebody in early before surgery? Do you wait till they develop some pain syndromes? How do you select the patients? Who are the right patients? What impact will it have? How much impact is worth it? What's the cost of therapy? All of those things are still being sorted out, but definitely there's a buzz around it during this meeting. Other things. What else have you seen so far at the meeting that interests you?
I just came in, Raj.
You just came in the door.
But I saw the program. But
what are you hoping to see?
Yeah, that's what I was about to tell. Because we made this as a pain medicine now. It's a new brand.
Yeah.
So we should think as it's a continuing of transitional, acute, chronic, and everything. So we shouldn't now think is like a fall is for a chronic pain.
Right.
It is like for everything now. So my big reason to come to this meeting is to see the fluoroscopy guided things, how to do, how they are doing, and to take it, if we can take it to the spring meeting, this big thing, the PNS stuff, okay, and the addiction stuff, some buprenorphine and other stuff, which we are not very good in those things, doing it as an acute pain.
Yeah.
Sometimes we may not be updated. So to learn all those addiction stuff, PNS, and specifically the fluoroscopy.
There's a lot of, ultrasound was hot in regional anesthesia and acute pain. And then the chronic pain physicians actually adopted, they were trained in it in residency and fellowships, and then they adopted it. And now there's so many procedures being done in chronic pain using ultrasound. I think there's now an interest in the other, which is fluoroscopy coming to the acute pain realm. Not easy to do. Not everybody has access to fluoro, but we're exploring the use cases. And there might be a lot of benefit in that translation back to acute pain and regional from education and learning that our colleagues in chronic pain have. Where do you want to use fluoroscopy in acute pain?
That's a good question, Raj. The main interest I got is when Brian Seitz visited us in Cleveland Clinic like 4 or 5 years back.
Yeah.
Their system in Dartmouth, they completely do even the acute pain epidurals under fluoroscopy.
Yeah.
Everything. Every epidural, everything goes under fluoroscopy. The system is so different. So then we started doing a little bit more with fluoroscopy, especially the aneurysm cases when you're putting a spinal drain blindly. If you have a blood tap, it is a disaster. The case gets cancelled, everything gets delayed, the surgery gets. So that's the main reason. One thing, difficult, morbidly obese, difficult patients, you are poking in the back where you don't know.
Yes.
The biggest reason for me is you get a wet tap, and they come for a blood patch. The reason
you're using it for blood patches?
Yes. The reason you got a wet patch sometimes maybe is a difficult epidural.
Right. So what makes the blood patch easier?
Yes. So then you are doing a blood patch. You don't want another wet tap.
Right. Right. No, it's a real issue.
It's
real
a real
concern.
issue with this difficult backs, with growing obesity. Especially for me, the biggest thing is for blood patches.
Yeah.
Okay. And even thoracic epidurals. If you see Brian Seitz, he hates anything other than fluoroscopy.
Yeah.
And the good thing is, if you do blindly, you don't even know where the catheter is. With the fluoroscopy, you can even test your catheter.
Right. And check your
not the technique.
spread.
Exactly.
All that stuff. Yeah. We take a lot on faith and then a lot of clinical acumen to determine if an epidural is functional or not. But all of us have dealt with epidurals that are clearly not doing what they're supposed to be doing. And then we're in trouble trying to figure it out. And often guessing at that point or replacing as the only solution. We don't have a lot of options at that point.
My second concern is with the increasing surgeries with robotic and laparoscopic and ERAS protocols, epidural is already dying. So the number of people doing the procedures to get the skill may not be there. If somebody is doing it in a better, safe way, maybe future is just with completely with ultrasound or fluoroscopy. Because they don't have enough number, they don't know what they are doing blindly. Because their training is going down and down in the
that's interesting.
thoracic epidurals.
So it becomes a specialty procedure.
Exactly. It almost will become a specialty
one of those basic regional blocks when we talk about how regional anesthesias evolved to having so many different options and then condensing it back down to like the 5 to 6 blocks. I think thoracic epidurals should definitely be in that ballpark.
But it's falling by the wayside.
It really
there's
has.
a lot of between hypotension, anticoagulation, rapid discharge from the hospital.
Exactly.
People are less and less likely to do epidurals for patients, and even surgeries that would be in the hospital
even
4 or 5 days.
Suggests that it improves, in terms of post-op respiratory status and all of that.
Yeah, but those studies were done pre-modern multimodal analgesics. So, like, I don't think we've seen a lot of recent modern multimodal plans compared against epidurals.
So are you saying we need to compare like thoracic surgery ERAS protocols against
proper opioid reduction, NSAIDs with muscle relaxants and maybe local anesthetics, maybe peripheral nerve blocks, fascial plane blocks of some sort, and then early mobilization and ambulation, minimally invasive surgery. All those variables are new since we've talked about thoracic epidural.
Very well because we did the ASRA coags app. Even the anticoagulants,
very complicated.
The new coagulants.
New coagulants, long-acting.
Anticoagulants change a lot of the landscape.
24 hours, 72 hours, 96 hours. You need to stop and you can't start. And trauma patients, they come in, they can't stop right away.
Yeah.
So they're already on these oral anticoagulants, long-acting, difficult to do the epidurals.
The benefit of these meetings is you can have these conversations with people in the hallway. Those hallway conversations are so valuable at this because we are learning where the specialty is going. I go to the spring ASRA regional meetings because I learn a lot of ultrasound guided techniques.
Yeah.
And now with having the reverse, exploring more fluoroscopy related procedures, which is great. I mean, you have translation across specialties, which is the whole point of this.
Yeah.
Which is absolutely the point of pain medicine. So I think it's beautiful to watch people learn like this and to be a part of it and to see what's happening next.
So what I find interesting, and I was talking about this when I was doing an intro earlier, is that in our spring meeting, we've been bringing in the POCUS folks. So it seems sort of tangential to the mission of Acute Pain Regional, but actually there's a lot of overlap. And so we've been bringing point of care ultrasound from that side. From the fall side, we've been bringing in psychology, PM&R, neurology, addiction. So there's a lot of interest
included into pain medicine and make them feel.
Yeah, so they're coming there, and then in the middle, we're crossing, right? So our acute pain POCUS people are coming to the fall meeting. Our chronic pain folks are going to, and so there is this leaning towards one side or the other, but there's definitely overlap and interaction. And in the middle is some sort of transitional pain, and that's kind of what ASRA Pain Medicine is trying to get to, is that this is a spectrum, and we're trying to capture all of that, And I think that's really valuable. The other thing that I've been really fascinated by, and Hari's, a testament to this, is our people are traveling. Our people are in the UK, Europe, India, South America, Africa, and the society is working really hard to build formal connections with the societies in those representative countries and to do information and people exchange of educators so that we are both growing and learning from each other. So you'll see in the future, very near future, a lot of intentional connections between these societies. We had a couple of our folks go to the African Society of Regional Anesthesia meeting recently, and then their president was invited here. I got to meet with her, Dr. Ayad, today. Wonderful person, huge amount of interest in both regional anesthesia and pain medicine in Africa, all over the country. Countries that she says as president, she doesn't always even know the name of the country. And she's like, but they're there. And they do webinars and seminars and workshops. And I think there's going to be a lot of this mingling. And we're seeing the international component in this chronic pain meeting represented as well.
Well, I mean,
that's a good point you brought, right? Because recently, as an example, we took Dr. Sam Naurozi and Ezra President Thomas Walk to the Aurora meeting in India.
Yes.
So recently in Mumbai, we took both the presidents there. It was like a great opportunity for the connections. We took Ed Mariano. So all the big people went there. So we all went there because it's our home country. We want to deliver our services to it. Amazing. They were shocked looking at the quality of the meeting, what they do in India, how the connections came up, interactions, what they do and everything. It was like the best first time. It is like presidents going all the way to the India. We felt so happy.
Yes.
It's like we felt very exciting.
And my understanding is they're also hungry for our content.
Exactly.
I expect an invite next time.
Yeah. Hey, that's my home country too.
Yes.
I was born in Punjab, man. Yeah. So
that is the thing. So,
Yeah.
so chronic pain is not that much established in India. So Dr. Naurozi told to them, please reach out to us. We will send our colleagues. Next time we add more content, whichever areas you want. So don't only doing what you are doing. You need to think
Build.
what others are doing.
And
Yes.
build it for 5 years, 10 years
Yes.
down the road.
Yeah.
So Ezra, the European Society, has not had a big presence in pain medicine.
Yeah.
They call it pain therapy there.
Yes.
And so they actually are they're about to follow our model where we rebranded from Azra to Azra Pain Medicine to emphasize the chronic pain and transitional pain component of that spectrum. Well, Ezra is now going to be called Ezra Pain Therapy. They're following the same model, and they've actually asked our society to help them with their pain program. And so we're a big part of the World Congress that Ezra is hosting next year in September in Paris for their pain portion of their program. A lot of that is coming from Azra Pain Medicine to help facilitate their program. And so we're seeing this across the board. The Latin American societies are super interested in collaborating with us. They want to be, again, sharing content, sharing education, coming to our meetings, us going to their meetings.
Because you brought up the Latin America thing, Raj, I want to share an exciting news in front of all of you.
Oh, wow.
So yeah, we are
Breaking news. Breaking news.
Yes.
I need a banner right
Yes.
here.
I was about to release the stuff today, just now. Yeah. We are converting all the Azra, how I do it, articles and everything to Spanish.
Oh, that's fantastic.
Yes. So I already got the approval for POCUS and major regional stuff.
That's huge.
So yes, huge. So POCUS is already done. So
Yeah.
it will come in a week or so. So all the Azra stuff, which is very unique for any traders,
Nobody does.
everything will be available in Spanish soon.
Wow. And I'll tell you,
That's a great achievement.
so again, we get asked all the time, why do I pay my dues?
Yeah.
What do I get from that, right? And if you look at the superficial level, you see some basic things, but there's so many things happening in the background that just make being part of the society better. This is a perfect example. We're not charging anybody for this translation. This is coming out of the investment that everybody makes in the society so that the society is stronger and more robust. That's fantastic. I think that's so
The
cool.
reason we did is I went to Colombia. We did like an Azra style POCUS course there.
Yeah.
Because being an Azra POCUS chair, I'm taking the POCUS to everywhere.
He's our ambassador.
So we did in India. Everybody was like fantastic. So we did in Colombia. I felt the language barrier was Spanish language.
Yes.
So I was talking, somebody was converting my language, and somebody was there with me converting into Spanish. They are good in English, but their Spanish was their main language. So I came back and I spoke to Dr. Naurozi and Angie. I said, I think we should do this. Hey, this is a great idea. There is Lazra is a big society with all the South American countries and everything. Let's do it, and we did it. So we are supposed to release today, but because of the busyness, we really didn't release the articles. It will be coming out.
But it's
week.
coming any day now.
It'll be all over the Twitter sphere, I'm sure.
And you know what I think we should follow at some point is that we've talked about doing patient education materials. We have some, but we can do more. And if we follow this, there's a lot of Spanish-speaking people even in this country that patient educational materials. If we take the same template and do that for our patient education stuff, that becomes a resource to our members to share with their patients as well. Not everybody has the access to develop
What if we change the ability of people to get information and from a non-biased source? I mean, if you want to look up things like about information about neuromodulation, you're often limited to other companies.
Yeah.
So wouldn't it be nice to have something?
It'd be nice to have a sort of an unbiased, credible source that we use as a reference point.
So you brought a very good point. So because there are so many things on the YouTube, people don't know which is true, which is false. That's why the Azra created the Azra videos.
Yeah.
So they kept some judges
They call it
there.
Azra Pain Medicine Best. Right?
Exactly.
And this is not
for the videos.
these
For the videos.
Well, see, these are videos that aren't necessarily created by the society, but created by members who are in the society, and they're even hosted on their own pages. We're just linking to them and then helping people kind of go to one place to find the best content that's of high quality and legitimate. And it's been reviewed by several people from the organization, so you know you're not getting garbage.
Yes.
And this is a library that's being built, so it's called Azra Pain Medicine Best.
Yeah, and it has a lot of resources, a lot of good resources. So I mean, I think it's going to be fantastic as it continues to grow in what content is available and is produced from the Astra Society.
So as we're wrapping up, I'm going to ask you, what do you still want to see during this meeting? What is it? What are you like hoping to get? Is there something for your practice and your experience that you think that you're hoping to capture during
I'm interested in seeing how neuromodulation can be used in underserved neighborhoods and areas. There's a talk on that. There's also one talk-wise looking at mitigation strategies for implantation infections, which I think will be really interesting.
How big of a problem? So as somebody who doesn't do these implants, how big of a variable is infection?
The probability can be low, but when it is devastating.
It's devastating. Yeah.
And everything we do means what we are doing. We're not doing procedures because people are healthy. We're doing them because they have chronic pain and they often have underlying conditions. Like if somebody has really bad back pain, they may also have other comorbidities that have led to that and make it worse. So you tell someone who has back pain that they need to lose weight, but they may not be able to because it's hurting so bad and stuff like that. So you think about that, whether it's other comorbidities that need to be managed or just that are not optimized. And if you could control their pain, they would be able to work in that in many manners. So you think about many risk factors that you could do better with, but the patients we're seeing are sicker and sicker, and we still need to take care of them, and we still owe it to them to be their providers. So I think learning about that and doing the best we can to give people the best. I mean, I'm in Arkansas, so I want to make sure that all of my patients get the same care that they could get at any other university or center across the world. Just because of where you live should not be limiting your access to healthcare, and good evidence-based healthcare is so important to what we do with our team. So that's really important, and I want to bring those skills back with me. My favorite part of these meetings is just meeting my people, meeting the people. It's wonderful. Hari and I haven't met in real life before until today.
Are you kidding? You guys have never met in person?
As we walked into the session.
I didn't know that.
For all I knew, you're just a floating head without a corporeal body. I mean, it's a relief to know.
He has so much energy, he's almost like a floating head. He's just bouncing around everywhere. So.
It's a pleasant reassurance.
That's so great.
It's wonderful to get to see people and meet them because as someone who is in a landlocked region, unless I leave my little bubble, I'm not going to meet people. Yeah. And I really enjoy that.
Well, there's a lot of people, I think, that in their practices, I think this is even more true for chronic pain than it is for acute pain, where there's a lot of people in small groups, small practices, and the conversations about innovation and new therapies and stuff can be limiting in those small groups. If you're not in an academically minded group, whether in private practice or not.
The world is a lot more small when you come to meetings like this in the best possible way.
Yeah.
It really is.
So I encourage those of you who are in those kinds of practices, one, is come to the meetings if you can. Come say hi. Everybody is friendly. Everybody will say hi to you and chat.
Because I can think of a few people within the
No, that's okay. I think we're going to probably wind it down. We've been chatting for a while and we had a really good conversation. So, come to the meetings. Come meet some of these people. You see all the crowds behind us. There's some wonderful people here.
And if it's intimidating, you can actually apply to have a mentor to help someone who guides you around the meeting too. So don't let that be something that's off-putting.
Yeah, I'm supposed to meet somebody here right now in a little bit. So
I mean,
they texted me, but I haven't
my
seen
first
them yet.
meeting, Chadwick Nichols had coffee with me, and then she introduced me to people and brought me into the wonderful warm world. We are all here to advocate for people who are in our sphere and who want to get involved. So it's a warm society. I definitely recommend it.
The other thing is if you're on social media, follow us on social media, interact with us, and we often get to know each other through social media, and that makes that first interaction in person so much easier. And we don't feel stressed by it.
I never felt Jarna was new to me.
Yeah.
It was like 1 second we are like, okay, we
Yes.
know each other.
Yeah.
So
absolutely.
I encourage you guys. So we're all on Twitter. Azra Pain Medicines on Facebook. We're kind of trying to expand our LinkedIn presence. So feel free to go find us. All the social media ambassadors are on the programs page for Azra.com for this meeting. You can find the social media ambassadors there and find their usernames. Follow those people. That's a great jumping off point. And for those of you who are young in this profession, networking early can be such a great launching pad to a whole career.
I can say my career is complete proof of that. My career is complete proof of that in every regards.
And most people here are very much interested in boosting you up. No matter what it does for their own career, they're interested in boosting you up. And what we find is in the end, it elevates all of us.
It's not an either or situation. It's a both and.
Yeah.
And that's the wonderful part about this group. It's both
Again,
and.
Azra has a mentorship program. So Azra has a great platform to help these people.
Join a committee, come to the meetings, interact with people on social media, get engaged, listen to the conversations, connect with people. That's what this is all about. And
that's a great summary. Thank you so much. Hari, thank you. Jarna, thank you. It's been so good to see you guys. Thank you guys for watching, and I hope you guys can be here at the next meeting. Spring Azra is coming up right around the corner. Get your abstracts submitted in a few weeks. That's coming right up, okay? Thank you, everybody. Have a great day. So that was great, guys.